Good morning, everyone. We will now begin this PATH Collaborative Planning and Implementation, or CPI, Initiative Best Practices webinar entitled Hospital Engagement in CalAIM, Supporting Connection to ECM Services Among Eligible Medi-Cal Members. I will turn it over to Lisa Bistrup from the DHCS team to get us started.
Hi, everyone. Welcome. We're excited to see all of the participants here today, looking to learn strategies to help support your engagement with CalAIM in the goal of improving the quality of life and health outcomes for our populations. By way of introductions, on this call today, we have Michael Weiser. He is the Chief of the Managed Care Program Oversight Branch. Shell Wong, she is the Chief over the Project Coordination Section. Myself, Lisa Bistrup, I am the Unit Chief over the Providing Access and Transforming Health, or PATH unit. On our Public Consulting Group side, we have Rebecca Rose. She is the CPI Administration and Contract Lead. Elise Memo, the CPI Workstream Lead. Karen Baldoza, the CPI Improvement Advisor. And we also have speakers from UCSF Health, Dignity Health, Marion Regional Medical Center, and Marshall. With that, I'm going to pass back over to Elise.
Thank you, Lisa, and the DHCS team. Our agenda today includes an introduction to PATH CPI Best Practices webinar series, followed by our hospital presentations. UCSF Health will present on partnering with ECM and MCP. Then Dignity Health Central Coast Hospital's Marianne Regional Medical Center will present the future implementing ECM and integrated care. And Marshall ECM will present on the evolution of our community care network. The hospital presentations will be followed by a discussion and audience Q&A segment, and we will conclude with closing remarks and an evaluation poll. During today's webinar, we will drop all available links to resources discussed in the presentation into the chat. Additionally, the slides and a recording of today's event, along with a Q&A companion, will be posted on the CPI website a few weeks following the webinar. As you listen to today's presentation, you can use the Q&A feature to submit questions to our presenters or CPI team. We will field some questions live during the Q&A portion of the webinar, type in responses to others, and address other relevant and common questions in the Q&A document that will be posted after the event. My colleague, Rebecca Rose, will now provide a brief overview of the PATH CPI initiative.
Thank you, Elise, and welcome everyone. So what is Providing Access and Transforming Health, or PATH? PATH is a 5-year, $1.8 billion initiative used to build up the capacity and infrastructure of on-the-ground partners such as CBOs, hospitals, Medi-Cal tribal and designees of Indian health programs, amongst others, to successfully participate in the Medi-Cal delivery system as California widely implements ECM and Community Supports and justice-involved services under the CalAIM initiative. PATH is intended to complement and enhance other CalAIM funding efforts and does not and should not serve as a primary source of funding. Funding for all initiatives is time-sensitive and time-limited and is not viewed as a sustainable, ongoing source of funding. There are 4 key PATH program initiatives: the Capacity and Infrastructure Transition, Expansion, and Development Initiative, or CITED, the Technical Assistance Marketplace Initiative, the Justice Involved Capacity Building Initiative, and where our efforts focus today, the Collaborative Planning and Implementation, or affectionately called CPI initiative. Next slide. The CPI initiative is a local collaborative planning initiative where collaboratives work together to identify, discuss, and resolve topical implementation issues. It also identifies how PATH and other CalAIM funding initiatives may be used to address gaps identified in MCP needs assessment and gap filling plans while avoiding duplications. PATH works with stakeholders in the regions to convene and facilitate county regional CPI efforts. There are currently 26 collaborative groups operating across the state of California, with 9 facilitating organizations hosting and convening collaborative work groups, collaborative meetings, as well as office hours. Over the last 12 months, our collaborative work groups focused on attention on optimizing referral systems, enhancing provider networks, and improving data exchange, among other key CalAIM implementation priorities. The funding for CPI is used to support the 9 facilitating organizations over the state of California. CPI participants are not and do not receive funding for this initiative, but entities are not required to participate in CPI efforts to apply for PATH-cited funding. Next slide. Since inception from August 2022 to current, we have 1,351 organizations participating in CPI. The organization types range from CBOs, Department of Health, and managed care plans. Areas of interest that are discussed during our collaboratives range from capacity development and training, populations of focus, and health areas of focus. Next slide. As previously mentioned, we have a collaborative operating in each county across the state of California. So from Alameda to Yuba County, there's strong representation within our collaborative convenings and organizations participating across the state. And with that, I will turn it over to Karen Baldoza to discuss our best practice webinar series objectives, today's objectives, and to introduce our first speaker.
Wonderful. Thank you so much, Rebecca. So in these twice yearly CPI best practices webinars, we aim to highlight best practices for implementation of ECM and community supports coming from all those organizations and collaboratives that Rebecca just shared. We also aim to increase providers' successful participation in CalAIM and improve collaboration with all organizations to build and deliver quality services for Medi-Cal members. And specifically on the next slide, you'll see that by the end of today's webinar, you should be able to state the value of hospitals engaging with CalAIM providers in your region, recognize opportunities for improved collaboration between hospital staff and ECM or community supports providers, and identify opportunities for warm handoffs and other coordination strategies between hospital staff and ECM providers to improve member connections to ECM and community support services. And with that, I'm very pleased to introduce our first 2 speakers from Dignity Health Marion Regional Medical Center, who will talk about the future, implementing ECM and integrated care coordination. So Marion Regional Medical Center began in 1940 when the Sisters of St. Francis of Penance and Charity opened Our Lady of Perpetual Help Hospital to meet the medical and spiritual needs of the Santa Maria community. And today the medical center serves Santa Barbara and San Luis Obispo counties. The current 191-bed acute care facility includes OB, NICU, neurosurgery, cardiac, trauma, and family medicine residency programs. Elizabeth Snyder is the Senior Director of Administrative Services. Her administrative healthcare career has included hospitals, ambulatory clinics, mental health and drug alcohol facilities, county health systems, academics, and population health. Nanor Darachdian is the Director of the Continuum of Care and a board-certified nurse practitioner with comprehensive experience across academic medical centers, end-stage disease management, transplant care, emergency medicine, and transitional care. Thank you both for being here with us today. And now I'd like to turn us over to you, Elizabeth.
Good morning. Thank you so much for the invitation. And thank you. I feel like today is a true celebration for our state as we all embark on this incredible opportunity to sort of help with the transformation of healthcare. And, we don't think we have any magic, but we certainly have developed, as my clinical partner says, some secret sauce that I think we're seeing some early results from. And so I tell all of you today and share some little tidbits only to be, I think, generous with what we've learned. And hopefully we all start doing that with each other and we can prepare for our future. So I appreciate we move on to the slides. And some of my slides really are just big picture for you. This shows you our map. And despite that our Marion Medical Center is the hub for us, we do have 2 other hospitals, several outpatient clinics, and we have other partners. But this is essentially our footprint that we work within to help ECM patients and our transitional care center. Thank you. We can move on to the next slide. So this is really very simple in a way. Why do we all want to participate in CalAIM and ECM to start? And we believe, and I think, have embraced the idea that this is something excellent for our future. We want to participate at the ground level like we're doing right now. And we are, I think, fairly convinced that CalAIM is going to shape and really significantly change the way medicine is provided. And ECM, the part that we get excited about with it is that it really is the ground floor. It is the place where we can meet patients quickly and in a more affordable fashion, way before the problems get much worse. We're excited that our partner CBOs have a true opportunity to work alongside of all of us because they are the crux of this approach, right? They are the crux of this healthcare worker population for us. We see this also as an opportunity for financial stability. So when folks, I think, wonder about how is it the hospitals are going to finance ECM, and one of the things that we did in our facilities is we looked around and we brought together our current navigation staff from various sections of our hospital. And we built a new team and we thought differently about it. So we created the Transitional Care Center about 6 years ago. We've applied for grants. We've applied for at-risk agreements. And we see this as the basis and the foundation for helping us fully implement ECM. We need this foundation to be successful. The opportunities for the PATH grants and our local MCP IPP grants have been very successful in terms of readiness. Sustainability will certainly rest with the new Medi-Cal revenue for us. Go to the next slide, please. So this just shows you quickly the framework for the Transitional Care Center. We sit in the Office of Population Health. As I said, the secret sauce rests with I think a clinical partner directing the clinical activities, and I handle the administrative aspects. Some of the unique positions on our team, I want to point out, we do have a population health analyst and we have our own registration staff so that we can be very efficient in terms of eligibility for ECM, treatment, and our ability to drop claims. You move to the next slide. These next 2 slides really just show you the growth that we've had with our CenCal population. That's our local MCP. And that, in the last 7 or 8 years, the growth of Medi-Cal is significant in our area. You please move to the next one. And clearly part of the whole sustainability rests too with this, the ability to have a dashboard. We are constantly looking at the length of stay, the CMI, the readmissions, and looking at all of our practice patterns for this population. Next slide. And this slide always makes me laugh. Nonor's generosity about all of our roles in this is kind of funny, but it really does show you that we need a little bit of everybody to make ECM work. It isn't going to just work with a clinician or the registration staff, right? It really is the administrative staff, the RNs, the community health workers, and the social workers. Next slide. And so this really is the overall arching kind of, the circle demonstrates all the aspects of care that we provide in the Transitional Care Center. And we are using the healthcare workers as the basis for it, and using our RNs and social workers to expand our service line. Next slide is belonging to now Nonor.
Thank you so much, Liz. And thank you everyone for having me. I'm super excited. Happy holidays all as well. I'm very excited about ECM because I feel like as a clinician, you know, my prescription pad only goes so far. And so we're finally able to sit in that space of whole person care. And as clinicians, we don't feel like we're on an island. So it's incredibly encouraging and heartwarming. This is the way healthcare should be. And so, you know, people will ask us, like, what value do you bring? And as Liz mentioned, we certainly do look at the utilization outcomes hospitals are interested in, the length of stay. We're not looking to shorten the length of stay to get people out. We're looking to be efficient with our time and resources while they're with us. And then as we shorten our length of stay, we measure how well we did that by also looking at our 7 and 30-day readmission rates. So it kind of balances it out. The other things that we've done are certainly, again, sometimes clinicians, respectfully, we feel like we're on an island. And so, you know, who's going to take care of the patient after they leave the hospital? And one of those places that we see a lot of utilization and a lot of avoidable utilization has been in the emergency department. And so we went and introduced ourselves and we let the providers know that we're a resource available to them. And they were hesitant to initially partner with us. However, I think one of the other secret sauces we have is that we're data driven. We're very scientific. We're very academic. I'm not just going to come up with a target if it's not rooted in our own community's epidemiology and certainly vetted against best practice and what the medical literature shows us standard of care to be. And so we circled around back to the ER providers and we let them know, okay, so you referred about 1,100 people to us in the ER, and they came in, all of these people that came in were all avoidable hospitalizations. These were treated and released patients. And after we had an interaction with them and we connected with these patients, they had a significant decrease in their ED utilization. Now, that was awesome to see the number of, to validate that feeling the providers were having. Anecdotally, they're like, I'm seeing some of these frequent flyers less. But then to be able to encapsulate it in a number and a value really punctuated our value and the critical need to address these very, while it may seem simple, PCP appointments, medication education, it makes such a big change. Next slide, please. Ooh, this one's very, very near and dear to me. So because I get to be a clinician too here, which is super rad. I love that. And once a week, I get to see patients that are either never established with a primary care and they need a bridge, or their primaries cannot absorb them yet. And so they need a bridge. And otherwise, these are also high risk for readmission and complicated ER patients that need to be seen. So we had this patient, and he was identified certainly from a referral from an ER provider because he was coming in a lot. And he had an open wound on his toe. So you think about diabetic, he's an unhoused individual. He doesn't have primary care. He was from out of state, now relocated in our great state of California. And the referral came to our team. Certainly, we recognize that this patient would certainly benefit from wraparound services and comprehensive care. And we engaged with the patient. They agreed for the support. We arranged for the PCP visit and all the things, very, very basic needs. However, because we engaged with this patient and we asked them all the questions, leading questions, we found out that this patient had no more diabetic medication. And he didn't seem to think it was a priority to mention. Nevertheless, we were able to, with the resource of having a clinician on the team, see this patient in clinic, make sure they had their diabetic medications, make sure that they had an appointment, also referral to podiatry, make sure he has his referral, refills in place, and wound care was taken care of. And so all of these things, this fun little story, ends up resulting in mitigating cost barriers for the prescriptions. It is eliminating that avoidable ER visit again to get more medications there, and really putting the care where the care belongs appropriately. So this is just one of many examples that we've had the pleasure of interacting with patients and then being able to provide all the things they need as a one-stop shop. I think that's it. No, it is not. The takeaways, my friend, we must foster a culture that moves beyond silos, please, embraces accountability for integrated, coordinated healthcare. We need to acknowledge that, yes, the hospitals are super fancy. However, most of the care happens outside of our hospital walls. And if we embrace technology and sit in this space of this is how medicine should be, the only thing that would be missing is having the confidence to reach across the aisle and say, hey, how can we work together for the benefit of this patient? I think that's it now.
Wonderful. Thank you so much, Elizabeth and Nenor. That was really a pleasure to hear your story. Before we move on, just a couple of reminders. As you listen to today's presentation, you can use the Q&A feature to submit questions for our presenters or the CPI team. We'll field some of the questions live during the Q&A portion of today's webinar, and we'll continue typing in responses to others. And then again, we'll address the questions we don't get to in the Q&A document, in a Q&A document that we'll post after the event. We're going to continue to drop available links to resources discussed in the presentation into the chat. And again, the slides and a recording of today's events, along with this Q&A companion, will be posted on the CPI website in a couple of weeks. So now I'd like to turn it over to our next presenters from Marshall to talk about the evolution of their community care network. Marshall is an independent health system in semi-rural Western El Dorado County. It includes a 111-bed acute care hospital built by the community and 16 primary and specialty care clinics with over a decade in outpatient interdisciplinary care management. Rachel Pei is the Executive Director of Population Health and an experienced healthcare leader with a strong commitment to integrated systems of community-based care with high-quality outcomes. Shannon McGuire Estrada is the care manager and outreach coordinator for vulnerable populations and a nurse with an incredible background of serving vulnerable populations in a wide variety of roles, leading ECM implementation and outreach at Marshall. And now I'm pleased to hand this over to Rachel.
Good morning. Thank you for having us. Next slide, please. So I know you gave a quick introduction about Marshall, but we're just so proud to be a totally independent, smaller health system. We do have 5 different locations in Western El Dorado County outside of the hospital, with multiple specialties represented. What I love is that Marshall created our interdisciplinary community care network team, which is what we call that team, in 2013. Really to help support the care of the 50 highest need patients in the community. before there was any sort of financial model. So really just what a wonderful commitment there. And we've continued to evolve that program over time to respond to community needs. Next slide, please. You could imagine adapting to enhanced care management requirements was fully aligned with our mission, but beyond that obvious alignment, our senior leaders quickly identified that engaging in ECM is a strategic priority to allow us to develop a sustainable program, as well as improve our ability to take integrated ownership of health needs in the community was really high on our list. So one thing that I love is while we do work with external ECM programs at times, truly having the shared language and program understanding makes those external partnerships even more effective. So I can say our program structure at first, we really tried to all wear multiple hats and just everyone engage all over for all of these different programs or all these different needs. We've shifted since then, and particularly with ECM, have recognized that having areas of specialty have allowed us to develop expertise and effective partnerships for particular populations. It also eases our ability to assign referrals to levels of service and specialist care managers. So we're not thinking, do you have capacity? Do you have the skill set needed for this population? Within this structure, I can say our clinical consult pool has been uniquely valuable. I can say especially our pharmacist for navigating medication optimization, just incredible story after story of impact there. And then unique things like a physical therapy assistant for patients who are housed, being able to address fall risk issues has really helped us lower our number of community-based falls that have led to hospitalization. And I can say overall, our all-cause readmission rate for our organization is at 8.94%, which we're very proud of. It's a 6 percentage point decrease over the last 3 years. Next slide, please. So as a whole, how Marshall has engaged with CalAIM, we've been very fortunate to receive funding to support our evolution and launch into this space. Specifically, the implementation of Compass Rose, which is a care management module, has allowed us to take the guesswork and manual effort out of figuring out when to follow up with patients, whether or not we've met all of our programmatic requirements. So we can really just focus on the patient needs and patient care aspects and not worry whether or not we've documented what we need to document. Beyond that, a really highly valuable effort has been intentional small group trainings on CalAIM related programs, referrals, eligibility, et cetera, and then follow up to evaluate engagement. We found that our care management team, social work roles, et cetera, are the easiest to engage, but really we've been intentional about not forgetting our practice directors and medical assistants. The really practical piece has been tailoring it to our eligible populations and which programs we've found most valuable so far, and then continuing to report out. Another piece has been expectation setting. It's very easy in the hospital for a case manager to think like, okay, ECM is going to help my patient get out faster right now. And it's, you know, we know that the reality isn't that always right off the bat. So setting those expectations about timeframes and that we're looking for long-term impact in our community and really expect to build this over time as opposed to expecting immediate results has been really helpful in creating a positive engagement there. Beyond that, partnerships in our community have truly been a clear cornerstone of CalAIM engagement in El Dorado County. Our PATH collaborative and relationships built out of this innovation have made it possible to successfully implement many elements collaboratively without duplication. We're really building on each other's skill sets and continuously learning what each other are capable of. Outreach and engagement. Marshall had begun a meaningful foray into intentional outreach into an unhoused population just prior to COVID. Enhanced care management and community partnerships have solidified our commitment to our community in this way, and we're thrilled we've been able to engage with the housing trio and medically tailored meals in particular. We've found that really consistent, reliable outreach in the community has helped us to develop trust and build those relationships in a meaningful way. And then with that, I'll hand it over to Shannon to share a wonderful patient example of how this has
Hi, thank you,
played out for
Rachel.
us.
Thank you, Rachel. So we have our typical hard to engage patient that's out in the community. He's a 61-year-old male living in a carport with oxygen dependent COPD, untreated diabetes. He has no primary care doctor, no phone, no income. Very difficult to just try to get that initial engagement. However, with working directly with our hospital case management during the interdisciplinary team meetings, he was referred directly to us. So this gave us an opportunity to better understand his needs, his barriers, his strengths. This also helped immensely to coordinate that initial engagement, that crucial initial engagement that seems so hard to get. We were able to get that with him. So I met him at bedside during his admission and was able to initiate the services. He consented to services. His issue with having no phone, we were able to provide him with resources so he could go to the library. We provided him a bus pass so he could go to the library and get a new phone. And, you know, we set up that first home visit so we didn't have to do the outreach through the phone calls. And, you know, so I went to the home visit and I learned what all of his needs were. We formulated a care plan, and then I assisted and educated him on how to schedule appointments with a new primary care doctor, mode of care transportation, how to refill his medications, provided him information on a COPD action plan, as well as a pulse oximeter, and utilized a lot of local resources by forging a lot of community relationships. So we were able to refer him to several outside organizations as well, such as like Paratransit, our diabetes nutrition education department, senior nutrition, because, you know, when you live in a carport, you don't have the ability to store medically tailored meals. So we utilized our senior nutrition program in the community. We also referred him to our local VOA, and then housing navigation services. Next slide, please. So the outcomes was he's managing his COPD under the guidance of his primary care. He knows when to schedule an appointment rather than waiting to go to the emergency room and having to be hospitalized. He successfully attended his diabetes nutrition education management training and now has a hemoglobin of a 5.6. He has stable nutrition. He knows when to utilize his resources for transportation. He can pick up his own prescriptions, so he's compliant with his medications. He's also working with the VA to establish income so he could better utilize the housing navigation services that we can offer to him. And so he's also working with an attorney for disability income. So he's doing pretty well in the scope of things. Next slide, please. So the lessons learned here is the timeliness of a closed loop referral. So with ECM, doing it at bedside enabled that initial engagement. It was completely closed. They referred, we came in, we provided services, we let them know what we did, we documented. And then also those relationships and partnerships within the community. That really enabled success for both with the initial timeliness of the referral and with all the services needed to develop this level of success. Thank you.
Thank you so much, Rachel and Shannon. Another great example from you all at Marshall. And I see that everyone with the questions are coming in, so I know those of you on the line have found the Q&A function, so please continue to submit your questions. We're going to get to Q&A after this next presentation. And again, anything we don't get to, we will post answers to on the website with the slides and recording after this event today. So now I am very pleased to introduce our final speakers from UCSF Health to talk about partnering with ECM and MCPs. UCSF St. Francis and St. Mary's hospitals are in San Francisco County, and combined they serve 7,000 unique patients per year with more than 30,000 emergency department visits, 8,000 inpatient encounters, and a combined average daily census of 145. Both hospitals see around 32% Medi-Cal patients and 45% Medicare patients. The ED at St. Francis sees the highest percentage of patients experiencing homelessness and behavioral health transports for non-city hospitals in San Francisco. Julie Maxon is a licensed clinical social worker and director of care coordination services at St. Francis and St. Mary's hospitals. She's worked at St. Francis for 17 years, where she was a psychiatric social worker in the behavioral health unit for 10 years, then moved to the medical side and worked in every department before becoming a supervisor, then manager, and now director. Alex Mitra is director of community health and government relations and leads their partnership and government relations work. Alex serves as a scout for the hospital, finding opportunities for the hospital in the community and opportunities for the community in the hospital. Prior to this role, Alex worked as a deputy district director for a state senator and senior public policy manager for a San Francisco advocacy organization. And now I will turn it over to you, Alex.
Thank you so much, Karen. Julie and I are very excited to share with everybody here how and where we found value in partnering with ECMs and MCPs. So as shared before, Julie and I work for two mid-sized hospitals in San Francisco. And as mid-sized hospitals, one of our challenges is that we aren't part of an integrated system that eases referrals between organizations. And so CalAIM gives us the opportunity to connect our patients to a wide variety of services that are in network in ways that we couldn't before. And so unlike our two previous presenters, we don't provide CalAIM services directly. And so, but because of our high CalAIM population, we engage with CalAIM as a facilitator. So we're screening and referring our patients for services that they're eligible for. We're setting up touch points to work with MCPs and ECMs, and we're supporting community partners to contract with MCPs so that they can build financial sustainability into their work. So we have, for this presentation, we're going to share with you 4 examples in the way that we work with the health plans and community providers to do that. So I will pass it over to my partner in crime, Julie Maxon.
Thanks, Alex. And thank you everybody for your time today and for the opportunity to talk to you. I'm going to jump into our case study. Next slide, please. Next slide, please. So this case study is about a patient similar to the previous examples that have been shared today, familiar, I think, in presentation to folks on this call. This patient was cycling in and out of emergency rooms and hospitals, typically with the presenting problem of grave disability, and often leaving the hospital as a self-directed discharge, otherwise known as an AMA discharge. He was unhoused, confined to a motorized wheelchair because of multiple limb and digit amputations, history of TBI, some cognitive impairment, many comorbidities, and chronic medical issues. Next slide, please. This involves a hospitalization where things changed. And what was different at this hospitalization, which was at St. Mary's, is that this patient was referred to an ECM provider, and he was assigned to an incredibly engaged ECM provider, Michael. Michael came and visited his patient in the hospital, and we started to cook up a plan together to discharge the patient to SNF, while Michael was able to set up a placement for the patient after SNF. So he was going to work on housing. We were going to work on the SNF auth. We found an accepting SNF. We got auth from his MCP, San Francisco Health Plan, but the patient was not convinced. And once he was strong enough to get back into his wheelchair, he asked to leave the hospital. So we, of course, supported him with what he wanted to do, and we encouraged him to come back if he needed help. And I meet with San Francisco Health Plan weekly. And in my weekly meeting with them, I told them what happened, and I asked to make a plan together with them about what to do when we see this patient again. And SFHP does something really interesting here. SFHP says to me, we're going to keep this SNF auth open. And so when he comes back to you, if he agrees to go to SNF, you just send him. And I don't know about the rest of you on this call today, but this is literally my first experience with a health plan saying something like this. And so, of course, I take them up on it before they change their mind. So anyway, 5 days later, patient returns, and so does good old Michael. I love Michael so much. And we pounce on this patient and we say, this is the plan we've got for you, same plan as last time, what do you think? And lo and behold, he's on board with our plan. And because we already have the auth, we can just send him right to SNF. So for us, this is an amazing success story. First, because we interrupt this pattern of ED visits and hospitalizations, maybe temporarily, but as you know, complex case management is sometimes a game of inches, right? But also because we help expand this patient's concept of future planning. SNF is now a discharge option for him. He's going to try it. And so that's a success for us as well. Let me further show the math on this. So what ended up resulting in this success is first you have a highly engaged ECM provider, right? Michael gets it. He knows how to reach his patient. He finds opportunities. He makes opportunities to reach this patient. And this is what I am looking for with something called enhanced case management. Michael really puts the enhanced into enhanced case management. Secondly, you have a highly empathic inpatient social work team. This is my team, and we do not weaponize a patient's self-determination against them. And by that, I mean, when we encounter patients who don't do things we think they should do, instead of blaming them or labeling them non-compliant or making the determination that they just don't want help, instead of all that, you have an inpatient case management team who remains patient-centered, trauma-informed, and looks for possibilities. And then third, you have a managed care plan here, San Francisco Health Plan, who decides to be open, responsive, and flexible to the needs of vulnerable populations. So everyone works together to organize service delivery around the patient. So all the patient has to do is show up. We're ready for you. We've got you wherever you're at. Next slide, please. Next, I want to talk about a separate but similar collaboration we have with SFHP. So to increase connections for their members to CalAIM benefits, SFHP wanted to fund a navigator for our emergency department who could connect SFHP members to things like ECM, housing navigation, primary care, behavioral health, et cetera, as a way to reduce overutilization of emergency services by diverting them to these benefits. But as I mentioned with that case study, the success of the case study actually came from disrupting that standard model of trying to shoehorn high needs patients into existing care delivery systems. Patients in the ED have a very brief window of time during which we can meaningfully engage with them for service linkage. And these CalAIM benefits all have these referral forms that you email and then you wait for a response, which is next business day if they're lightning quick, but turnaround time is more like a few business days. And then they want to contact the patient by email or maybe by phone. And I probably don't have to tell any of you that when a high utilizer of emergency services needs something, they don't send an email. So SFHP very kindly supported our disruption of the single navigator shibboleth, and we used the contract to set up the I am Spartacus model of navigation, meaning when you ask who is connecting SFHP high utilizers to CalAIM benefits, any person on my team can say, I do that, I'm the navigator. Next slide. Oh, no, sorry, stay on this slide. Oh, and I'm sorry for sharing Bilbo's PHI here. So the way this works in practice is we created a dot phrase that lists each element outlined by the SFHP contract for the navigator function. Any member of my team can select this dot phrase, which populates into the EMR in this format you see here. It prompts each element and even embeds contact information so anyone can navigate that member to primary care, enhanced case management, behavioral health, and housing navigation. Why do we do it like this? Because we may be able to have a single person in a single location in the ED perform this function, but it just seems more likely that we will catch more patients and sustain more interventions if navigation can happen anywhere the patient is. Maybe in the ED, but maybe in the ICU, maybe in tele, maybe med-surg, maybe on our burn unit. Basically anywhere there is a case manager and some runway of time to establish rapport and accomplish this task. Next slide. So finally, I have to really shout out the commitment of SFHP to meeting with me weekly to discuss complex patients, to co-create members. I think next slide, actually. Yeah, thank you. To problem solve barriers to connecting health plan members to their benefits. We've been meeting for some time now. And after some initial tension and frustration at the beginning of our collaboration a couple of years ago, we have now established a true culture of trust. And that trust has really allowed us to engage in enthusiastic, disruptive care planning on behalf of our patients. We take risks together. We challenge the assumptions we had about what is possible for how to help very complex and super vulnerable patients. And that has led to some truly wonderful outcomes and heartwarming success stories that inspire us to keep it going. Thanks, everybody. I'm going to turn it over to Alex.
Thanks, Julie. Next slide. So as I said earlier, the biggest win for a hospital like ours is to help create a health system that works for patients at our hospital. And that means finding like-minded partners to do the work. And that's really where the Path CPI collaborative shine. Really, it brings everybody together that you're never going to schedule all at one time. The information sharing and networking is well worth the time. You learn about partner barriers and opportunities, which really guide you to where the areas of opportunities to collaborate actually exist. I'll give you one example. I was working with a community partner on a medical respite project. One, we found the community partner for the medical respite project at that CPI collaborative meeting. Two, we were talking about how to get a consultant for that project off the ground. We work with a lot of consultants. They're very smart, but they never set up medical respites or build MCPs. So what did I do? I went to the CPI collaborative and I talked to the MCPs to see who they work with. I asked who did good work, who didn't do good work. You do your research, and those are questions you can't find on the internet or on a phone call. And that's where the CPIs really shine, being able to ask those below the level questions. Spotlighting partners is another crucial thing that honestly, it doesn't take money, it just takes paying attention. As a hospital, one of our competitive advantages is we have closer feedback loops on which organizations and referral pathways work best for our partners, work best for our patients. And so we're able to shout and flag those individuals so that MCPs and funders are able to expand their scope. And we've done that with one of our favorite street outreach partners. I know we're at time, so I'll skip the last part, but really, next slide. When you're looking to partner with hospitals, look at HCI's reports on Medi-Cal, homeless, where those patients are going. That's how you're going to identify where you're going to find a more receptive audience. Ask those hospitals, what are their barriers? And if you're asking, who do you talk to community health, talk to care coordination, population health. Every nonprofit hospital has a community benefit plan. There's a contact name and number on there that has my contact. It probably has somebody from Elizabeth's team. That can be your entry point, knowing that hospitals can be a little challenging to get a first contact with. So those are a little bit of tips and tricks, and then I'll pass it back to Karen.
Wonderful. Thank you so much, Alex. Thank you, Julie. And a huge thank you again to all of our presenters. We hope everyone listening in today can walk away with something you can try locally. With nearly 900 people in our virtual room here and around 40 questions in the Q&A, we won't be able to get to every question, but thank you for submitting them. Again, we're going to take a few of those questions now and we'll post those we're unable to get to in a Q&A document with the slides and recording after the webinar on the CPI website. So let me turn to the questions. And I'll start with Elizabeth and Ninor. We have a question that came in that said, how do you present this strategy to hospitals to obtain cooperation and buy-in? And were there any contracting adaptations that were required?
Oh boy, both of those are such good questions. The contracting was easy. The MCP was thrilled to contract with us, and we have I think a pretty good solid relationship with CenCal. So that was the easy part. The question about explaining this to the executive team was a a long time in coming. We have a VP that has seen the light. She was committed to population health and CalAIM 5-6 years ago and really understood the future. And she and Nenora and I have spent the last 5 years with data and constantly putting it in front of people. And it has made a giant difference. And because I hate to say this old-fashioned expression, but the proof's in the pudding, right? When we can all produce good outcomes and show what our investment does, it's hard to negate. And so now where we are this many months and years later is that we have our nice dashboard that we send out proactively every month. And I think that really helps.
I will follow that up because we also have a question about your dashboard. It said, great to see your data dashboard. Are you tracking the impact for individual patients as well as monthly aggregated data? And if so, is the impact data collection process automated, or do you need to get data manually? For example, impact before and after ECM interventions. Would love to hear more about the process for data collection.
I'm going to defer the majority of that question to Nenora, but I do want to say that the question is really, really good because as I talked a little bit about in the presentation, having a population health analyst full-time on our team, thanks to the IPP funding, has been a game changer. So I think I can't overemphasize enough that when folks have priorities, if you can have an analyst, I think it is a giant improvement. So Nenora, please, you answer the rest of the question.
If you don't have an analyst, you can be like me and read 14,000 encounters and synthesize what you find because you don't watch TV. However, that is likely what people are not looking to do. We had a period of time here where we had to create our own system to collect data. And that was done through our Google Suite and forms and synthesizing it that way and then being able to produce our data very literally and very honestly in that regard. Everybody on our team has access to these forms. The questions are standard across the board. Our interventions are standard across the board. And so everybody was able to identify what they've done for the patient. And then we were able to synthesize the volume of intervention. As far as before and after, so yes, definitely we do it for the entire population. We can do it for a payer plan. We can do it for, there's a lot of ways we can slice and dice it for a more high level view. As far as looking at it from an individual patient view, it has been painfully manual up until most recently we got a new technology and we have been very much involved in the customization of our dashboards. So therefore, it will be automated for us now in producing what their utilization, let's say, for ED was before and what it is now after interaction with our team. So painfully manual, almost there to get it automated.
Great, thank you. And now I have a question for Rachel and Shannon. Someone has said, I'd love to learn more about your staff training process on CalAIM. Can you share more details about your internal CalAIM communications and training process? And specifically, do MCPs and community supports providers also contribute to and participate in staff trainings?
Yeah, that's a great question. I would be happy to connect offline as well if you want specific examples of the materials. But big picture, what we typically do is we actually bring the referral forms from the plans with us, especially since those referral plans do have the payer-specific eligibility requirements on them. We also have a really excellent slide. I'm sure all of you guys have seen something like this, but from our past CPI, they maintain a very up-to-date listing of all of the different vendors and who they're contracted with, which populations they support, and which community supports they offer. So I include that. And we go through specifically some patient examples and how the process works. So it's it's a very practical way of approaching it. And as far as participation from the NCPs and community supports providers themselves, they are more than willing and able to jump in and help. We've just found that starting with some internal training and then engaging with the MCPs or then engaging with our past CPI does put on highlights of different community supports and ECM providers. So we'll take people along to those more past CPI related groups later on. Although I can tell you both Anthem and the Health Plan of San Joaquin have offered a handful of times they're more than willing to come on site and train staff as well.
Thank you, Rachel. And I know we just have a couple minutes left, but I want to make sure that we get to this question for Julie and Alex. Someone has asked, could you please provide guidance on how to approach hospitals for potential collaboration? Any best practices, contacts, or resources you can share would be greatly appreciated.
You want to take that? I'll take that. I would just look at the community benefit reports, see if there's contacts in there, reach out, and then be specific about the problems that you are looking to solve, where populations you are successful at supporting, and then go from there. And then do be dogged, because sometimes you do have to cut through the noise a couple times and people have a lot of things going on. But I would definitely phone call, send an email, and then try to name those organizations, the areas in which you think it would work, whether it's care coordination, inpatient, ED, or the clinic side, depending on the hospital's reach. Julie, is there anything to add?
Yeah, definitely what Alex said, but also just remembering that, you know, we are talking about entities, but the success of all of these projects is about the people who are most enthusiastic about making them happen. So when you talk about approaching a hospital, you're just going to find, you know, someone like me or someone like Alex who is like, yes, when can we talk? Can we talk all day about this? You know, and if you get somebody who's like, I'm not sure if we're interested in that, or I'm not sure how we can create the bandwidth for that, or that's not something in our, you know, current time frame, you're talking to the wrong person. You're going to find somebody who wants to talk to you, make these connections and make them happen. And they don't need a ton of, I shouldn't be saying this on a call with so many participants. They don't need a ton of permission. They just need the people who are willing to make it work.
Thank you so much, Julie. And thank you again to everyone. I, like you, Julie, feel like I could talk about this all day. But unfortunately, we're running out of time. So I do want to start to wrap us up. Thank you again to all of our presenters, Elizabeth, Lenore, Rachel, Shannon, Julie, Alex. You are truly inspirational, and we thank you for all that you're doing in your communities. And thank you to all of you for attending today and what you're doing in your communities. We hope you have found inspiration for your work. And now I'll turn us over to my colleague, Rebecca, to close us out.
Thank you. And thank you so much again for everyone for joining us today. If you haven't yet officially registered to join your local collaborative or the CPI in your region, we do encourage you to visit our capath.com/collaborative website and register for one of the collaboratives. All of our collaboratives are seen here on the screen for you. And again, each county and region in the state of California does have a CPI collaborative for you to join. We do conduct our biannual best practices webinars twice a year, and we are already in the planning stages of hosting our next biannual best practices webinar, tentatively scheduled for early June, but please be on the lookout for more communications on our next best practices webinar. And as you see, we've just launched a poll. We do appreciate your attendance today, and we do want to make sure that all of our webinars in the future are useful and engaging to you. So we would appreciate, before you exit today that you do take a moment to answer our best practices webinar evaluation poll. We do appreciate your assistance with completing that poll. Much appreciated. And shortly after the webinar, we will be collecting the best practices webinar materials, the Q&A questions that were not answered today in a document that will be posted on our website. Also, too, I know that some of you may have had some issues and problems, and we apologize. Accessing the links that we were trying to send along to you today, but all of the links that we've referred to on our presentation today will be included in our post-meeting materials that will be uploaded to our website. All who have registered for today's webinar will be receiving a notification via email that these materials have been lifted up to our CA Path website. And with that, again, thank you everyone for attending. Thank you to all of our presenters. I hope you have an amazing rest of your day and a joyful holiday season. Thank you so much, everyone.